This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. It's fall vaccine season. As kids get back to school, the political debate around who should get shots for COVID and other illnesses is once again bubbling up. Changing federal recommendations have left doctors and patients confused about what shots are available and if insurance will pay. And last week, President Donald Trump used a platform of the presidency to promote unproven ties between Tylenol, vaccines, and autism. We'll have more on that later this hour. As federal health guidance shifts, some states are going in their own direction. Connecticut recently announced a new regional partnership with other Northeast states and New York City to combine public health expertise and resources. Joining us now is Dr. Manisha Juthani. She served as a professor of medicine at Yale and is the commissioner of the Connecticut Department of Public Health. Thank you so much, Commissioner, for being with us today.
Thanks for having me.
And for our listeners, let us know if you have any questions or concerns, 888-720-9677, or leave us a comment on Facebook and Twitter at Where We Live. So just mentioned the Northeast Health Collaborative. So, Commissioner, can you tell us about it and why is it needed today?
What we noticed when 2025 really kicked off and we started to see a change in the approach to public health with executive orders that started, with changes to grant terms that we had, with changes to funding, with grants that were cut, we realized that we were in a new environment where we were going to have to adapt quickly and try to figure out how we were going to address these changes. So as commissioners of health departments, we talk on a regular basis through professional societies that we have, usually on a weekly basis, on a national level, but even on a regional level. Mm-hmm. And because many of the Northeast states have similar modalities of public health, and we are small states where people cross borders on a regular basis for work, for school, for activities, it made a lot of sense to be able to work with each other and figure out how we were navigating these differences. So we started talking at the beginning of the year and really enhanced those efforts. And when we realized that all these changes were happening, we felt the need to work more collaboratively, not just as health commissioners, but as state epidemiologists who really look at the data that we bring in on a daily basis, looking at our immunizations programs, looking at a lot of our infrastructure that we have. And so we realized that the collaborative could be helpful because we needed to bring in people more than just state health commissioners. We needed the people who actually help us make the work happen on the ground. And so that's really what started off the Public Health Collaborative that has been going on since January. We did announce the collaborative to be able to have people understand the work that was happening as changes were happening. Mm-hmm. And that's part of the reason for the announcement that we made.
Well, then when you say we, so who are the states that are involved? And it sounds like you're sharing a lot of information and resources that you were already sharing previously, but sounds like more today.
So the number of states involved has changed, it's broadened, and I think there are many that have been involved, but when you make an announcement, there is something involved in that that's a little bit different than just working together. Mm-hmm. And so what I would say is that the announcement certainly highlights states that have been involved since the beginning, states like New York, Massachusetts, Connecticut, and Pennsylvania, and the like, and several others, including New York City, so that we have states that have their own health departments, and then we have big cities that have their own health departments. So it is really a combination of both, especially in the Northeast where we have several big cities. But I can also tell you that there are states that might not have been announced per se in that initial press release that have been involved and continue to be involved. And there are various groups that are going to opt in and opt out because, unfortunately, public health has become quite political and quite partisan, and even though it really shouldn't be either. And so different states have to make choices that work for them. At the end of the day, we are not trying to create any sort of regional infrastructure that supersedes either state governance nor federal governance. And quite frankly, we don't want that. We are beholden to our state statutes and federal statutes. And we're not trying to create something else that actually takes the place of either of those things. What we're trying to do is do good public health work and utilize resources we have to do that.
Well, I'm glad you brought that up because I believe it was last week during a media event, you told one of our reporters, Sujatha Srinivasan, last week that we are not, let me capitalize, not establishing any body outside of the state or federal government. There has been no move to create a regional CDC, none. So this is something you said. Why do you feel like you need to clarify that?
That was specifically in response to a press event that was held last week where there were many people protesting a regional CDC. Mm-hmm. And there were many signs in the room that said no regional CDC. And I wanted to make sure that the crowd that was there understood that we in no way are trying to do that. And what we are trying to do is leverage resources for people among the states that we help support to be able to make sure that we ensure access and choice to those who want things in our state. And so in that room, there was a vocal group who did not want vaccines. There was a vocal group who did not want mandates. And we are in no way mandating anything. What we are trying to say is, if you want a COVID shot, we want it available so that you can have it. Mm-hmm. And it's been that way for the last 5 years, and we just want to be able to help ensure that it can stay that way. And so that's the type of access, information, and choice that we are trying to ensure for people. And right now we're in a situation where it is a little bit unclear, and we do know that people have hit barriers, and we're trying to remove those barriers.
And that leads to my next question really is there is a lot of confusion right now about vaccinations and what families across the state have access to. And so what do Connecticut residents need to know about vaccines this fall?
So the main thing to realize is that there's really a three-pronged approach to vaccination. The first is what is recommended by the health department, by your doctor. What do we think there's scientific information to say that this is a vaccine that we believe is in your best interest to take? The second is who can administer it. So we have pharmacists that are regulated by the Department of Consumer Protection, so not by the Department of Public Health. And we have pediatricians as an example. And we work with pediatricians specifically to distribute vaccines, but pharmacies operate separately. And so that's why we've been working with the Department of Consumer Protection and Commissioner Caffarelli to be able to help ease those barriers that people might have. And then the third is insurance. What is going to be covered? Now, there are certain state-regulated plans, which are regulated by Commissioner Mays and the Connecticut Insurance Department, third state agency. Again, this is why it is a three-pronged approach. And fourth, which includes our Department of Social Services and Medicaid, because that's another big payer of vaccines in the state. And so you have all these different departments within state government, which the Department of Public Health does not have oversight over all, and that's why under Governor Lamont's leadership and through that collaborative effort, we've tried to clarify for people who should get the shot, where can they get it, and will it be paid for? And what I can say is that from the payment perspective, those that are regulated by the state all have to pay for the shots that are recommended, and that's been pretty clear. One thing that we've seen from the national organization that oversees a lot of privately insured programs. So, for example, if you have insurance from a large employer, that's considered a self-insured plan. Mm-hmm. And those plans are governed by ERISA, which is federal law. We do not have oversight on that in the state. And the large employers have largely said that they are going to pay for it. So that is at least reassuring. Mm-hmm. Now, I think that there are other things we can continue to talk about in terms of where these hiccups may be occurring right now in terms of access. But what we really tried to do a few weeks ago is confirm that vaccines are safe and effective, that we in the state of Connecticut want to provide that kind of access and support people to be able to get vaccinations should they want them.
Well, especially since conversations, of course, are still ongoing. And as you mentioned, trying to reassure families that this is the safe it's a safe thing to do, or you recommend them to do so. Are you hearing that reassurance from families who are concerned, especially now that we're back in the school season? And of course, I think most of us know this is the time where everyone has a cold or something because we're all gathered.
Yes, absolutely. So what I can say is anecdotally, and certainly through some of our data that is starting to come in, COVID sort of seems to have taken off first. Mm-hmm. And I do know a lot of schools that have seen a lot of COVID cases in this first month of September. Now, often, because we do not have all COVID tests reported to the state anymore,
right,
there's a lag in hospitalizations and deaths. And so I anticipate that, again, as more vulnerable populations get COVID going into the rest of this fall and winter, we will start seeing those numbers, which are consistently reported to us, ticking up even more, because I see a lot of healthier people getting COVID right now. Now, October is our big month when we really want people to get vaccinated against flu and COVID. And flu, the ACIP, which is the Advisory Committee on Immunization Practices through the CDC, and what we have said consistently is that anybody 6 months and older should get a flu shot. It is safe, it's effective, it's been done for decades, and it certainly reduces the morbidity of flu in our communities. With COVID, although we recommend it for everybody 6 months and older as well, there are two populations that really can benefit the most. Those 65 and older, and 6 months to 23-month-old children. So our youngest and our oldest. And, particularly in that pediatric population, there are new babies being born every day. Pregnant women benefit from getting a COVID shot. For your average child and adult who may not have comorbidities, that would definitely say that they should get a COVID shot. It is still recommended, in my opinion, because it reduces the severity of disease that you may have yourself. It helps protect those youngest infants who can't even get vaccinated. It helps protect pregnant people around you, older people around you. So it's still our recommendation. And I do think that some of that message is getting through. I think there, though, is still a lot of noise and there's a lot of confusing messaging. So that's where some of the confusion happens. Again, I mentioned the ACIP. The ACIP also voted similarly to what we're saying, which is 6 months and older, everybody is eligible to get a COVID shot. However, what they wanted to make sure is that there is shared decision making, that people are aware of the risks. And that's true, quite frankly, for any shot that you take. We really want people to be aware of whatever risks there may be and make sure that they're fully aware and that it is a shared decision. And so that's something you can always have with your doctor or somebody that it's administering the shot to you.
Well, and amid the noise, too, even so, Connecticut has one of the highest vaccination rates in the nation. But last week, as you mentioned at the media event, that there were protesters that are voicing their concerns over vaccines. Are you concerned about the growing hesitancy of vaccines in the U.S. and here in Connecticut? Are you seeing it locally?
So I think we certainly are hearing from a certain group that is hesitant. And I think that is not a uniform group. There are people that may be hesitant about one shot, about two shots, that generally are okay with most of their shots. And so there's really a spectrum of this. And I do think that some of what we're also seeing is that because there is a lot of noise and confusion around this, there are people who may not have been hesitant who are now saying, well, maybe I should think twice about that. And is this the right thing for me? What I can also say is that there are many diseases that, because we've done so well with the reduction of certain diseases with vaccination, there are things that people don't even see anymore. And so there are things in my lifetime that we can talk about. Let's take chickenpox, for example. I had a bad case of chickenpox when I was 12 years old because I didn't get it till then. There are many, many children who have never had chickenpox.
Right.
And we don't really see it that often anymore. I can tell you, as an infectious disease doctor, shingles later in life is a horrible disease. I'm not just talking about a rash on your body, whether it could be meningitis or something else. We have meningitis in infants that, because of the Haemophilus influenza vaccine, which is a bacteria, used to fill our pediatric wards with children who used to have meningitis, where that is not the case anymore. In real time, we're seeing this with RSV. Every winter season, we would see pediatric wards filled with kids with RSV, door after door after door. And with the monoclonal antibody or vaccination for pregnant women that we're seeing, we're already seeing a change in that tide. When that happens, you see a great reduction in infectious disease burden, potentially a bigger influence of chronic disease burden. And I think people start to forget what the burden of infectious diseases actually does in our society.
Well, you mentioned some of these vaccines that are typically taken when we were kids. So there's also been confusion over this as well, because federal guidance has changed on the measles, mumps, and rubella and varicella, which is chickenpox, as you just mentioned. So those guidance have changed on these vaccinations. So can you talk about what's going on there?
It is a little bit of a complex story and nuanced. And so I'm going to have to go through a little bit of detail to really help people understand it. So at 12 to 15 months of age, we recommend the MMR vaccine, which is measles, mumps, rubella, as you mentioned, and the varicella vaccine. At 4 to 6 years of age, we recommend both of those vaccines as well. It used to be that kids would get 2 shots for both. In the early 2000s, a co-formulation was developed just to have a 12 to 15-month-old potentially have 1 less shot and a 4 to 6-year-old have 1 less shot. So the MMRV as 1 shot was developed. When that was brought to market, what was identified was that there was a slightly increased risk of febrile seizures, meaning that young children, when they get high fevers, they can sometimes have a seizure. And when you took the combined shot, MMRV, it was higher in the 12 to 15 month of age, but it wasn't in the 4 to 6 year old range. So what most pediatricians would say is at 12 to 15 months, they recommended getting the 2 shots because even though it was an extra shot, at least you reduced that potential risk. But at the 4 to 6 year old range, they recommended the 1 shot to have 1 less shot for the child. It used to be that the shot was approved for both age groups. And in the state of Connecticut, in the 12 to 15 month age, 17% of parents chose to get the combined shot, the 1 shot. They accepted that risk potential of increased risk of febrile seizure. Only 17% of parents chose that. The vast majority of those people were in private practices, about 5,000 people every year. And what the ACIP voted on a week ago, almost 2 weeks ago now, was that they no longer recommend it for that 12 to 15 month age group. So that vote, when you say recommend, that ties usually to lack of insurance coverage, but it depends on the provider.
Right.
For the state and federally funded programs, that ACIP language of recommend ties to coverage. So what that now did is it said that parents who chose to get the single shot in that 12 to 15 month age no longer have that choice. Some of them may be able to have the choice, may need to pay for it though. And so they would need to check with their insurance provider and with their pediatrician. And so to me, that was disappointing because this was a choice parents had. And now those 5,000 families every year, for whatever reason, you may have a child that has some comorbid condition or has a serious fear of syringes and vaccines.
Right.
And maybe a parent says, that 17% of parents says, you know what, I'm willing to take the chance on a febrile seizure to have 1 less shot for my child. Now those families will have less choice.
Well, I want to take a moment to remind our listeners that you can give us a call and share your stories or concerns with us, 888-720-9677, or find us on Facebook and Twitter at Where We Live. I'm going to take a moment to grab a call from John, who is calling to us from Richfield. John, you're on the air.
Hi, thank you so much for having this discussion.
Of course, go for it.
My wife and I have been having a really hard time actually getting access to the COVID vaccine, to the pediatric COVID vaccine over the past couple of weeks. We tried at our local pharmacy and they said they wouldn't administer it, whether they had it or not. And then we actually made an appointment at a chain pharmacy a little further away. And when we got there, even though they allowed us to make the appointment, they said they didn't have the supply. So we're getting a little bit into panic mode of like, is there even pediatric doses available, or what is this going to look like over the next couple weeks?
Well, thanks, John, for sharing your experience. And anecdotally, we've also on the team here heard from other families who went to their pediatric doctors and they did not have the vaccine at the time. So, Commissioner, is this something that you're hearing?
This is absolutely something I'm hearing, and this has been top of mind for me for the last week. And I need to explain a little bit of how our vaccine supply works in the state of Connecticut. So, John, thank you for raising that question. I think there are two parts to this. The first is about going to a pharmacy. Now, many of the pharmacies do have pediatric vaccines, but different pharmacies are having challenges as it relates to what they feel they can or cannot do. So the first is that there was the PrEP Act that was passed federally during COVID that basically said that children 3 years and older could go to a pharmacy and get vaccinated for COVID or flu. Now, we also have state law that says if you're 12 and older, you can get a pediatric vaccine, any kind of pediatric vaccine, in a pharmacy. However, there is nuance around COVID and COVID vaccines in particular. So because of this confusion, pharmacies are choosing to interpret what they can or cannot do differently, and different pharmacists are working on that. So this is something that we are working with our Department of Consumer Protection to really talk about with the pharmacies in terms of what can or cannot be done in pharmacies. Because again, as I said, I do not have oversight on pharmacies, but this is an all-of-state approach. We are in constant communication with DCP, and I have raised this concern over the last week and will do so again. I appreciate the real-world example that you shared, John. But I do want to also take a moment to explain something that is in my control and that we are seriously concerned about. So I explained the ACIP vote that happened now 10 days ago. Now, normally in the state of Connecticut, we have a universal vaccine purchasing program. What that means is in 1994, a federal law was passed which said that all vaccines for Medicaid children, uninsured children, would be covered by the Vaccines for Children program, which is a federally funded vaccine program. And we purchased those vaccines through the CDC. In 2012, the state of Connecticut passed a law so that all children in the state of Connecticut could have their vaccines purchased by the Department of Public Health, the way that we do for VFC. And this became our Connecticut vaccine program. And our insurance providers in the state are assessed essentially a tax that allows them, it's an assessment. That assessment on the insurance program and the insurance providers in the state, funding through that, again, comes to DPH so that through the Vaccines for Children program and that insurance assessment, together, we have funds to purchase all vaccines for children that get their vaccines through pediatricians in the state of Connecticut. That ACIP vote that I mentioned that happened on a Friday, normally the CDC director signs off on the vote immediately. That is what then dictates us being able to start ordering vaccines. And that did not happen on that Friday. And then all of last week, those ACIP votes were not signed off. And so we as a state have not been able to purchase those vaccines to date off of that CDC contract. So we are working fast and furiously to work with federal colleagues and partners and think of creative ways that we could solve this problem. But John, I do know that this is a problem certainly in pediatricians' offices, but I will take your concern back also to our pharmacists and our Department of Consumer Protection.
And thanks for your question, John. We're currently speaking with Dr. Manisha Juthani. She's the head of the State Department of Public Health. Coming up, she'll stay with us and talk about the scientific and medical groups that are pushing back on comments from the Trump administration on autism and Tylenol. You can also join the conversation, 888-720-9677, or find us on Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Catherine Shin. President Donald Trump used the platform of the presidency last week to promote unproven ties between Tylenol, vaccines, and autism. The Associated Press reports that the administration promised this year to determine the cause of autism by September. But that claim has baffled many brain experts who say there is no single cause and that the rhetoric appears to ignore decades of science on autism. Still with us is Dr. Manisha Juthani. She served as a professor of medicine at Yale and is the current commissioner of the Connecticut Department of Public Health. And we're now also joined by Colin Killick, who's the executive director of the Washington-based Autism Self Advocacy Network. Colin, thank you so much for joining us on the show.
Thank you so much for having me. It's a pleasure to be back.
And so we mentioned a little bit earlier, too, that last week President Trump said women should not take acetaminophen, also known as the brand name Tylenol, during the entire pregnancy. He also said pregnant women should tough it out to avoid taking the pain reliever because of unproven claims that taking it heightens the risk of autism in children. Can you respond to what we heard last week from the Trump administration?
I mean, it is just baffling, and frankly horrifying, although that this administration's rhetoric on autism has been that way pretty consistently, right? I mean, it was only a few months ago that Secretary Kennedy came out and said that autism destroyed children and destroyed families. And he gave this laundry list of things from, playing baseball to writing poetry to getting married that autistic people supposedly can't do, which I have to say baffled those of us who are autistic and are well aware that autistic people can do all of those things. But yeah, I mean, there was essentially no evidence for this claim. They're going off a single study, which found a fairly weak correlation that hasn't been found in other, I think, frankly, higher quality studies. And it's also just striking because, I mean, we know that fever during pregnancy is dangerous. And so to make a recommendation to do something that, to not control that fever seems to me reckless, although, of course, I'll yield to the commissioner's public health expertise. But the thing I've been saying, as we've been talking about this, is that this administration talks so much about autism and seems to care so little about autistic people, because we've been pretty loud and pretty vocal that we do not appreciate what this administration is saying about autism, that the claims they're making are inaccurate, and that we would like to see a very different direction for autism policy from our government.
Well, Commissioner, I want to ask, as a medical doctor as well, can you respond to the president's remarks? What message do you want to send to parents out there who did take Tylenol during pregnancy?
So, as I said in the press conference last week as well, pregnant women want only the best for their child. Anyone who's had a child knows that they would sacrifice so much to ensure that their child is as healthy as possible. And there are a lot of things that happen in pregnancy, including if you have a fever, which could be very challenging. And we know that having fevers is not something that we would advise pregnant women to continue with, especially if it's going to be prolonged.
What are some of the risks there?
So, look, we don't know all the risks. We know that these are things that are continually evolving. Could there be neurodevelopmental risks? Is it possible? That's possible. We don't know when we say, even in this one study that may have not been as profound as some of the more rigorously done studies that are out there on acetaminophen and autism. Is there a potential that there is some association? Sure, but that does not prove causation. And there are two different things. When you have something that happens at the same time as something else, that is an association. So, for example, in the summertime, if there are a lot of shark bites and a lot of people eating ice cream, they happen to have at the same time. But most people would say, I don't think there's really a relationship between the two. What we don't know at this point in time is Tylenol actually associated with the development of autism? What we know of autism so far, as Colin accurately pointed out, it is a complex situation and also one that there is a range of manifestations in different people and in different ways. And to simplify it, to say that taking any Tylenol during pregnancy might result in autism, I think simplifies a much more complex scenario. In fact, I believe that it produces potentially shame in women who may have taken a dose of Tylenol during pregnancy because they really needed to, because really there's nothing else to take. Ibuprofen is not safe. Aspirin is not safe. Those have been proven to not be safe in pregnancy. And so as somebody who has had children, as somebody who's had to struggle with those choices, and quite frankly, we talk about, is there a genetic component to autism? Are there environmental factors? Are there other things that result in the development of autism? There is enough guilt and shame to go around in anybody who has actually bore a child, that to add on top of that something for which we have limited at best evidence, I think is going a step too far. And I don't think that we want autistic children and adults to have to think about, did my mom take Tylenol when she was pregnant with me? Maybe that's why I'm in this situation. That does not create, in my opinion, a productive, forward-thinking situation as we go forward.
When Colin, building on what the commissioner just mentioned, there's blame being put on pregnant women. And this is something that dates back decades and decades, right, Colin?
Yeah, well, I mean, in different ways, right? And this is an important thing to point out, is that our understanding of autism has evolved, right? And it's all sorts of half-baked theories got thrown around over the years. So, decades ago, there was this notion of refrigerator mothers, right? Before people understood that autism was developmental and that, autistic people are autistic from birth, right? Mm-hmm. I mean, probably, from conception. Firstly, we know now autism is genetic because we know it runs in families, right? But they used to talk about refrigerator mothers. They would say, oh, women who are too cold and emotionless to their children, that makes them autistic, right? We know that's nonsense now, but it was blaming mothers. It was saying, oh, the mother did something wrong, and that's why the child is autistic, right? And this is, in a different way, bringing that idea back, right? Of, oh, you did something wrong to make your child autistic. And the important thing to point out here, right, is the lack of science or rationality here. I was in the room back during Secretary Kennedy's last round of Senate hearings when he said outright, we know that there has to be an environmental cause for autism. We're not going to research genetics anymore. Rates have gone up. Rates can't have gone up this way without an environmental cause. So we know there has to be an environmental cause. We're just looking for what it is, right? So he had already closed his mind to the possibility that in fact this wasn't caused by some kind of toxin. And so they cast about to find something that they could make the claim for. And I guess they settled on acetaminophen. The truth is, though, there's actually no evidence of a supposed autism epidemic. There is no evidence that autism is actually more common now than it was decades ago. What has actually happened is that we have expanded the diagnostic criteria for autism multiple times as we've come to understand it better, right? Things like, folks have probably heard of Asperger's syndrome, right? That used to be a diagnosis. It's not anymore. That's now just part of autism. And someone like me, who's, has relatively lower support needs, I would likely have been diagnosed with something like Asperger's in an earlier era, right? But now we know that there's no clear line there, so that's not part of autism. The other thing, too, is that we've spent all this time and money and effort on finding autism, right? On these early identification campaigns, on making sure people know the signs of autism. And so it shouldn't be a surprise when you work harder at looking for something, you find it more often. And that's a good thing because it means more people can get the supports that they need.
I just want to reiterate exactly what Colin said. When we talk about rates of autism going up, this is true in anything in public health that we do. When we start looking for things and we find them, rates will go up. That is part of what happens when you come up with more refined diagnostic criteria, more access to resources for even diagnosis, which the goal ultimately for is early intervention, early attachment to different resources so that people can benefit most during those earliest developmental years and end up on a track to be able to live life to its fullest. Because we know that so many people over time may need less resources, may become more independent and more sufficient on their own abilities, that early intervention is key to this process. So, this idea of more cases yes, there may be more that have been identified, but that's part of the beauty of what's happened so far.
And Colin, before we go to break, I want to talk about what are you hearing from the autistic community right now?
Yeah, I mean, people are upset. They think that this announcement is ridiculous, and people have been, making fun of it. But they're also really angry that our community is continuing to be stigmatized, and particularly that autistic people are being talked about like some kind of plague on society, right? The way that the administration talks about autism, as though like being autistic is the worst thing a person possibly could be, and as though the existence of autistic people is this national crisis. And they're saying openly that they want to get autism rates to zero. And for those of us in the community, well, the only way to get autism rates to zero is for us to not exist. And that scares people.
And actually, Commissioner, I have a last question for you in terms of medical treatments, because we've also been hearing a lot of, is it leucovorin?
Leucovorin.
Where it's a prescription form of vitamin B9. So can you respond to this as a possible treatment for autism?
So I think that in medicine, we often will take a medication that was used for one purpose and see that it actually has a benefit for something else. So for example, in my wheelhouse of infectious diseases, AZT used to be a cancer treatment, which was then identified as the first HIV drug. The idea of using something that could be useful for another condition is a good thing. That's scientific inquiry. But then you test it. You have a hypothesis. You do a study. You find evidence. And you go beyond that. And you do scientific investigation and research. To date, I am unaware, in my knowledge, of convincing data on leucovorin and autism. So I would be concerned without seeing that data. And if it's out there, I welcome reviewing it, but I have not seen it to date.
You've been listening to Dr. Manisha Juthani, who's the commissioner of the Connecticut Department of Public Health. Thank you so much for joining us today.
Thanks so much for having me again.
And Colin Killick is the executive director of the Washington-based Autism Self Advocacy Network, and Colin will be staying with us. You can join the conversation after the break. What do you think about the recent federal comments on vaccines or on autism? Give us a call, 888-720-9677, or find us on Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. Last week, President Trump urged pregnant women to tough it out and use Tylenol sparingly during pregnancy and claimed an unproven link between acetaminophen and autism. Autism, a developmental disorder, has increased in prevalence. That's according to the U.S. Health and Human Services. And with us still is Colin Killick. He's the executive director of the Autism Self Advocacy Network. So, Colin, you've described autism as being an inherent part of the human condition. Can you talk more about this? Should we be reframing how we think about autism?
We should. I mean, yes, autistic people have been around as long as there have been people. We just didn't used to describe it that way, right? In the early 20th century, people who were clearly now would be seen as autistic were diagnosed with, childhood schizophrenia and that kind of thing, and got terrible treatment as a result. But really, I mean, the way to think about this is in terms of neurodiversity, right? Human brains function in a variety of ways, and autistic people's brains function differently. And that's not to say that life as an autistic person doesn't have some inherent challenge. It absolutely does. Autistic people have, a wide variety of, and in both in terms of type and degree of sort of functional impairments. But autistic people also have strengths. And the fundamental thing I want to emphasize is that despite Secretary Kennedy's rhetoric, autistic people are not destroyed. Life as an autistic person is very much worth living. And not just, people will say, oh, well, you have low support needs, whatever, you don't have an intellectual disability, not all autistic people are like you. And that's true. But life is worth living for all autistic people, right? And including autistic people with high support needs, including autistic people who have intellectual disabilities, including autistic people who are non-speaking. I know thinking back to what he said, I know non-speaking poets, right?
Mm-hmm.
I know autistic people with intellectual disabilities who are experts in their fields and who are, married and who have kids, right? I know, autistic people who are athletes, right? Autistic people have, well-rounded, fulfilling lives. And the thing that autistic people need to have the best chance of those kinds of lives is the sorts of supports that are, for instance, available through Medicaid and that have been endangered by the cuts that this administration has forced through.
Well, and there's a phrase, Colin, used in the disability community more broadly that says, nothing about us without us. Could you explain what that means?
Yeah, it's the idea that decisions about our lives should not be made without us at the table, right? Which has historically been the case, right? People with disabilities have been spoken about, they have been spoken to, but they have not really been spoken with, right? There's a lot of other people assuming that they know what's best for us. The reason that my organization, Autism Self Advocacy Network, exists, and it's that self-advocacy part that's important, is just because historically, all of the major autism organizations in this country were not run by autistic people, did not have autistic people seriously involved. And they were pushing rhetoric, including often this rhetoric about how life as an autistic person was inherently terrible, that really harmed our community in a variety of ways, including creating this sometimes deadly stigma around autism. Basically telling families in some respect to give up on their kids, right? And so our organization came around to say, no, a life as an autistic person is worth living, and autistic people should get to meet other autistic people, should have access to autistic community, and that autistic people were experts on our own needs. And so that's really what's happened. And I think that over the nearly 20 years of ASAN existing, we've done a lot to shape autism policy in this country by saying, here is what, as autistic people, we feel that we need.
Well, then talking about policy, you've come on the show previously, too, to talk about the recent changes in the legislative levels on how that can impact the autistic community. So can you give us an idea of what are some of the recent moves that were made by the administration that perhaps makes it more difficult for autistic people to get the support that they need? And especially since I think a lot of people with autism rely heavily on Medicaid, right?
Yes. So I want to talk about two things. Firstly, Medicaid, exactly. So autistic people, people with developmental disabilities, intellectual disabilities broadly, depend heavily on Medicaid services for things like rehabilitation, for various kinds of therapy, for even in-school supports of various kinds, right? All kinds of community integration. Medicaid pays for home care workers. Medicaid pays for group homes, which can be of varying quality. Medicaid is absolutely crucial to autistic people being able to live independent lives in the community. And most of those services are what are called waiver services, right? Which means that they are optional for states to provide. States have to file for a waiver with the federal government to spend Medicaid dollars on those things. Whereas there are other kinds of services for that states have to provide under Medicaid. So the reconciliation bill, the so-called big, beautiful bill, there was nothing beautiful about it that got passed, is going to force hundreds of millions of dollars in Medicaid cuts over the next several years. And because these services are optional, they are likely to be on the chopping block unless there's a real, efforts to fight like hell at the state level to stop them. I'm sure in Connecticut, you're going to see disabled advocates speaking up to try and protect these services, and hopefully state legislators are going to listen. But it's a tough position to be in because this federal funding is being taken away. Well, the other thing I want to mention, sorry.
No, go for it.
Research, right? At the same time that this administration has talked about how much they prioritize autism, they eliminated tens of millions of dollars in funding for autism-related research through the National Institutes of Health and the CDC. And this included studies, some on the causations of autism, but also on other health issues that affect autistic people, and canceling research programs that would have really helped autistic people, including things like developing better diagnostic tools informed by the lived experience of autistic people, as well as, for instance, eliminating a suicide hotline resource that was specifically for autistic people, and eliminating programs to help autistic people find careers in STEM, right? So again, this administration talking a lot about autism, taking away things that directly help autistic people.
Well, that actually answered my next question that I was going to ask you anyway, is what are some of the concerns at the forefront of your mind? And I know you kind of touched on this a little bit earlier, but are you hearing a lot of fear in the autistic community right now about what the future might hold, especially if they expect or already had their services taken away from them?
Yeah, I think people are afraid of loss of services, and they're afraid of um, further stigma, further marginalization, right? I mean, this administration has also been talking a lot about how much autism costs the government, and the figures that they throw around have been incredibly overblown. But yeah, I mean, the word is eugenics, right? There was a whole movement in this country whose slogan was "Some people are born to be a burden on the rest," right? That talked about how the existence of disability was bad for the country and how the world would be better off with fewer disabled people in it. And so the kind of rhetoric that they're using are, again, I keep coming back to this, but it's describing autistic people as having been destroyed, right? When you think of someone as having been destroyed, that means you're giving up on them. It means you're saying it's not worth spending money and time and effort on them because they're already lost, right? You just need to keep more people like them from coming into being. And so we're really worried about those consequences. We're really worried when we hear them say they want to, get autism rates down to zero, because again, you can't cure autism. Autism is it's genetic. It is written into who somebody is, right? And you can see that just, I am autistic. I have 2 autistic first cousins, right? Like you see autistic people, it runs in families. It's more common amongst, siblings because it's developmental. So yeah, there's a lot of fear around what does this administration have in store for us?
Well, and of course, you're in the trenches and are very much involved in everything that's happening right now. And as the conversation continues, is there something you would like to leave for our listeners today? What do you hope they take away from this conversation today?
So I want to firstly just come back to, again, there's no evidence of an autism epidemic. This is just the case of changing definitions and better surveillance. I also wanted to come back to this thing around leucovorin that you were asking the commissioner about. And just to situate that, because there's a long history of people, including people in the kind of circles that Secretary Kennedy used to run in, pushing so-called autism miracle cures, right? Saying to families, here is the one thing, give your child this and they'll magically no longer be autistic. And it's a pretty ugly history, right? There was the so-called miracle mineral solution, which turned out to basically be bleach, right? Which had serious consequences. There is still, in some seedy corners of the world, people pushing the idea of chelation therapy, which is, a thing for removing heavy metals from the body as a supposed autism treatment. And not only does that not work, but we know of at least one autistic child who died as a result of chelation, despite which Secretary Kennedy has spoken approvingly about chelation, including in a Senate hearing that I was in. And of course, David Geyer, who is working with Secretary Kennedy and who we know has access to at least some autism data inside the government, was sanctioned for giving Lupron, which is a testosterone blocker, to autistic boys without a medical license, under the claim that that would cure or improve their autism, which it did not. Now, compared to all of those things, leucovorin's side effects are quite mild, but again, it's something being claimed as an autism cure, autism treatment, with no evidence that it works.
Well, thank you so much for sharing your experience with us today, Colin. This is certainly something that we will continue to follow up and update. You've been listening to Colin Killick, who's the executive director of the Washington-based Autism Self Advocacy Network. Thank you so much, Colin, for spending time with us today.
Thank you so much for having me on.
I'm Catherine Shin. Today's show is produced by Tess Terrible. Our technical producer is Dylan Reyes. Download Where We Live anytime on your favorite podcast app. And thank you all so much for listening.